Professor Khadija Humayun talk would focus on endocrine transit disorders in neonates and when to worry about these transit disorders. She will discuss common transit disorders in detail in neonates and how to differentiate benign, self-limiting conditions from those requiring interventions. It shall also focus on clinical red flags, appropriate investigations, and when timely treatment or referral would be made. So, Professor Khadija Humayun.
Assalamu alaikum, everyone, my esteemed colleagues, neonatologists, endocrinologists, and thank you for inviting me. I was looking forward to be there in person, but unfortunately, due to a family emergency, I couldn't travel, but thank you for the kind invite. I hope you are hearing me clearly and you can see my screen. And so I'm going to talk about the transient endocrine disorders in neonates. Most of the things that I would be talking about would have been covered by my esteemed colleagues in their talks in depth, in detail. And some of them would be covered later, maybe tomorrow. But here, what this topic entails is for me to sum up those things where the neonatologists need to know when is the time to worry or when is the time to intervene. I have no conflict of interest to declare, and this is the overview of my talk. So after the objectives and importance, I'll be covering some of these topics. And if we look at the last bullet, the question about genitalia, my question to myself was, do I really need to cover? But then I thought about it. And it is actually with these queries that we usually get the consults from our neonatal colleagues. And the literature also talks about it. So I thought it was pertinent that I include these. So if you see, why are we worried about these transient endocrine disorders in neonates? We know many of these abnormalities or so-called abnormalities are either a physiological response or are transient and would go away. But the high stake of the situation is either we are mistreating or missing the diagnosis. So we need to have a very clear balance between the two so that the babies should not suffer. As I was listening to the question and answers with my esteemed colleagues and Professor Khalid, as he rightly pointed out, treat the baby, not the number, except when the number predicts harm. So I think that should be the motto when we are handling these situations. So we have to really distinguish between the transient and the pathologic endocrine patterns. We need to know when to repeat these tests or when to treat immediately because it is the baby's health at stake. And also we need to know the red flags where an early endocrine input is needed. So the final aim would be have an emphasis on bedside decision-making. Instead of isolated lab values, go for algorithms. You develop your own algorithms, as rightly pointed out previously. And the ultimate outcome should be a safe, standardized approach across the unit. So why do the neonatal, or rather the NICU endocrine tests may mislead. We know very well that you are handling the prematurity and acute illness, and both of that alter the endocrine axis. And we also know that medication and iodine exposure specifically affect the thyroid, the TFTs. And we also know the stress response of whether it's prematurity or illness would affect the cortisol and glucose values. So we'll have to, most of these results will have to be interpreted in the context of gestation, the clinical stability of the baby. We have to avoid the screening panic during acute illness, and we have to follow the trend rather than a single data point. So with that background, let's start with individual areas. First, I would like to talk about the thyroidal illness. And when I talk about the thyroidal illness, I would be dealing with three specific conditions, which I think we face mostly in the neonatal units. The transient hyperthyroidopeninemia. And I think Dr. Rehan would be covering that or has already covered in his talk about this. But the transient rise in the TSH is very common in the preterm, in sick neonates, with iodine exposure and also with the maternal thyroid disease. What would be the pattern is a raised TSH with a normal, near normal T4, free T4, which is done. So in that scenario, if we see a venous blood TSH, which is less than 6 milliunits per liter, it is considered normal. Anything between 6 to 20, we need a follow-up. Usually recommendation is to follow about 2 weeks, repeat the TFTs. But if we find a raised TSH, which is more than 20 milliunits, the recommendation, the general consensus is to start the treatment. Yes, of course, send the labs further evaluation, but by that time, with the rise as high as 20, we need to start treatment. What do we have to do? As I already pointed out, repeat in about a week, 2 weeks, and of course, at the end of the neonatal period, at the end of 4 weeks. Also, please review the iodine exposure. I know it's becoming less and less common in developed countries and in good centers, but we just cannot ignore it in our population. So treat if we have a low free D4 and the TSH is persistently high on the repeat. These transient hyperthyroidopeninemia cases may need to be followed up long term. And we all know we cannot give a trial of the levothyroxine before 3 years unless the levels that we are requiring of thyroxine replacement fall down to less than 25 micrograms in these babies. So we have to keep that in mind. Then the next thing that we will talk about is the so-called sick thyroid, which is a condition which we see in older children, adults, and specifically it is called as low T4 value, low thyroxine of prematurity. What happens here is usually seen in the preterm sick infants. And here, whether we are checking the T4 or free T4, they would be low. And we may have a normal or low TSH. So you see here, both the things are on the lower side. And it often is a reflection of illness, immaturity, preterm babies. So what we have to do here is repeat these tests once the babies are stable, near term, near their corrected age. Please don't reflexly start levothyroxine unless there is a true hypothyroid picture. So low T4 or low free T4 is the giveaway with a highish TSH. And if both are low, you may need to repeat. Then we go to the other extreme, the transient neonatal thyrotoxicosis. We come across this situation usually by the maternal illness, like Graves, where the TRAB or the thyroid stimulating immunoglobulins transfer through the placenta, and this is the commonest cause. Or the mother suffering from Hashimoto's and using high dose of thyroxine, or use of iodine as an antiseptic. The clues that we get here is the tachycardia, irritability, poor weight gain, thrombocytopenia. And the labs will show a suppressed TSH, a high free D4 and T3 or free T3 with a TRAB antibody being positive. So you see, in the thyroid related illnesses, this is the first one where the use of T3 comes in, because pure T3 toxicosis can also happen. How do we treat these? This is one condition where the treatment is needed. This is one of the treat now condition, and we have to think about giving propranolol plus minus the carbimazole, methimazole, and supportive NICU care. This condition usually presents around 3 days to 10 days after birth. And since there is cardiac risk involved, it is better to treat now. It is always good to have the maternal history taken antenatally from the OBGYN team. And we, for the neonatologist, we have to check TRAB in at-risk pregnancies. I know there was a time when TRAB was not available in Pakistan, but luckily there are many labs who are doing it. Just one important thing that I want to mention. It is a rare incidence, but there are babies who are on high-dose biotin therapy. Now, this situation can cause a falsely elevated T4, T3 levels with a low TSH, which may simulate hyperthyroidism, so beware of this situation. After this, let's move on to the next condition, the adrenal and electrolyte issues. Dr. Jeda would be talking about the electrolyte imbalances. I think her lecture is tomorrow, but here I would briefly go over the issues that are transient but can cause some confusion with the situation, and we need to be aware of. So let's first talk about the adrenal insufficiency. Two terms are used here, the transient adrenal insufficiency of prematurity. Here the cause is the adrenal axis is not fully functional before the 30th gestational week. And for babies who are born premature, we may face this issue. Similarly, the term CIRCI, or the critical illness-related corticosteroid insufficiency, is used. And here what is happening is the cytokines in acute stress would suppress the ACTH and cortisol synthesis. The tissue resistance develops against cortisol. There is also reduced blood flow to the adrenal gland in these term or preterm babies. Also, if there was use of corticosteroid antenatally, a picture of adrenal insufficiency will develop around the 3rd to 10th day of life. How do we take it? So we have to make a diagnosis. And here again, this is one situation where it is more dependent on clinical diagnosis. Cardiovascular issues would be faced. There will be persistence of hypotension, oliguria, hyponatremia, despite what you see is you have been giving fluid inotropic support, then you have to think, is everything okay, or do I need to look into some other things other than the heart? And although a figure is given of finding a random AM cortisol of less than 10 can be suggestive, but in true essence, sometimes it is very difficult to find these values with all the pre-analytical issues we face with our lab samples. And if we are doing the synactin test, which is supposed to be the gold standard in these adrenal situations, the increment of cortisol value is less than 9 above the baseline. Now, if we have a strong clinical suspicion, we have to give a short course of low-dose hydrocortisone. And when I say low dose, it means around 5.5 milligrams per kg given every 12 hourly after a loading dose of 1 mg per kg. And once we give the loading dose, if we see a blood pressure improvement, that is suggestive that our thought process was clear. But we can't go on long with this situation. We have to reassess daily and avoid prolonged courses and taper as soon as the baby is better. So again, this is a clinical diagnosis and labs are supportive, but not perfect. Now, this is one situation which mimics what my colleague Dr. Sumaya has talked about, the congenital adrenal hyperplasia, mimicked by the secondary pseudo-hypoaldosteronism or the PHA type 4. What happens here is a UTI or an obstructive uropathy would trigger and lead to hyponatremia and hyperkalemia with acidosis. And we all know that these are some things, especially in boys, which are suggestive of CAH. So when we send the workup, despite all the difficulties in interpreting the 17-OHP levels with all the problems that we face, it may be normal, near normal, if we have taken all the precautions of interpreting it with the gestational age and with the age of the baby. The renin would be high, and over here, the aldosterone would actually be very high. We tend to see levels as high as more than 100. But in addition to this, the clinical scenario would be suggestive either of sepsis and, some obstruction. So a renal ultrasound and urine culture is always a must. Now, this is another situation where the treatment is a must. We have to temporize using ways and means to treat hyperkalemia because that can be life-threatening. But of course, as Dr. Sumaya has very correctly pointed out, when we are talking about hyperkalemia, we need to be sure about it that a free flow sample has been taken and it is not due to the hemolysis of the blood. We may need antibiotics. We, of course, need to correct the sodium, give fluids. But as a rule in this situation, just like the pseudo-hypoaldosteronism type 1 and 2, mineralocorticoid usually are not useful and are not needed. So once the electrolyte, the infection or obstruction is taken care of, the electrolytes normalize. So just a cautionary note that having normal genitalia does not always rule out CH. Now we move on to the next group, disorders with the calcium. And over here, let's first talk about the commoner version, the hypocalcemia that we see early versus late. Early means less than 72 hours, prematurity, small for gestational age, infant of diabetic mother, perinatal stress and asphyxia are all the contributory factors. Whereas the late ones presenting after 72 hours is mostly due to the high phosphate load which these babies might be receiving in their total parental nutrition. They might be due to vitamin D deficiency, which can be in the mother and transferred to these babies, or maybe due to hypomagnesemia. So we need to look at these. The workup that needs to be done in these cases require the total and ionized calcium check wherever it is available, checking the phosphorus, and of course, magnesium parathormone and vitamin D, especially in the late cases. So we need to treat, of course, we know that hypocalcemia is a very common trigger for seizures leading to asphyxia and hypoxia. So we have to treat the baby to prevent the seizures, calcium replacement. And if we find a low magnesium, then correct it. If there is vitamin D deficiency, we need to take care of that. Remember, if the magnesium is not corrected, the calcium would not budge, because we know that magnesium is a very important factor required for the parathormone to work correctly. Now, going to the other extreme, transient hypercalcemia. Again, as Dr. Huck has very rightly pointed out, the numbers are controversial, but most of the literature has suggested that a total calcium of more than 11 milligram per deciliter or ionized calcium more than 5.6 deciliter is taken to be hypercalcemia. And what causes it? There is phosphate deficiency. Again, that can happen in the total parental nutrition when we are not careful of the ratios that we are supposed to maintain. When there is a high vitamin A and D intake by the mother or through her with the newborn, maternal hypoparathyroidism, and the subcutaneous fat necrosis, which is very commonly seen post-birth asphyxia, in severe hypothyroidism, even in the extreme of thyrotoxicosis, or excess of calcium in parenteral nutrition. How do we manage this? We have to discontinue the intake of calcium and vitamin D. Phosphate is given to bind the calcium and chelate it. We have to diurese these patients, usually by giving less 6 infusion, and sometimes the steroid therapy is also needed. And if none of this is working, we tend to resort to use of bisphosphonates in severe cases. And of course, in the neonate, we usually use the intravenous forms. Moving on, let's talk about glucose dysregulation. Although I think it has been discussed in detail in the previous session, but let me just touch upon it. So the definition of neonatal hypoglycemia is controversial. What is the number? It has changed over time. And why is it important? We have to identify a threshold at which the treatment would prevent brain injury. Now, thresholds will vary with the gestational age, with the postnatal age, with concurrent metabolic demands, comorbidities, available of alternative metabolic fuels, and very correctly pointed out that in various centers, it would vary depending on the type of babies that they are usually seeing in their unit. So, but from literature, the most widely used definition was a number where they pointed out 2.6 millimoles per liter or less than 47 milligrams per deciliter. But again, that may not be true for your units. What are the risk factors for this transient neonatal hypoglycemia? You have already gone through this, but all these factors can lead to it, and we have to have a good history to really find out if that is the case, that is happening. From there, we move on because the treatment has been very correctly dealt with in the previous talk. I'm moving on to the transient hyperglycemia or the stress dysglycemia. Again, the numbers are controversial, but the most common numbers given is a serum glucose, which is more than 150 milligrams per deciliter. This is the sample that we send to the lab to be checked. And the total blood glucose, more than 125. This is the bedside glucometer test that we do. It is very common with the stress, which increases the blood glucose level. And all these etiologies which lead to stress can cause the stress dysglycemia. We have to manage by reducing the GIR. We have to manage by optimizing the nutrition. And of course, we have to treat the underlying cause. Insulin is to be given only if the hyperglycemia is persistent or severe and requires very close monitoring. And please remember, insulin as a bolus is always disaster. So if you are thinking about insulin, think about a very low dose infusion of insulin rather than using it as a bolus in these babies. Okay, now we go to, as I told you, I was thinking whether to present this, and then I decided to go for it. So, transient clitoromegaly in the newborn girls. The enlargement of the clitoris, again, the number is a little controversial because this number may be different for different population, but unfortunately, in our part of the world, we do not have the norms established. So we have to rely on the norms which are already there. And the most commonly used number is a length more than 10 millimeter. What can cause this? A breech delivery, a difficult labor, edema of the genitalia, ecchymosis, SGA babies, and prematurity. And why does this happen? There is increased level of dehydroepiandrosterone in these preterm babies due to the persistence of fetal zone activity in the adrenal gland. And in addition, the liver is not able to clear away the DHEAS, the sulfated version of DHEA, as a result of which the androgen exposure is there, and that leads to clitoromegaly, which is transient. So once you have taken these, I think I should also add something here, is the maternal exposure to high doses of progesterone. That also can lead to a transient clitoromegaly. So please do take the history and think about these and not only CH as the only cause or DST to be the cause of this clitoromegaly. Then we go to, again, a problem faced in newborn girls, the neonatal uterine bleeding. Menstruation in a neonate is usually a physiological temporary phenomena, sudden withdrawal of estrogen, progesterone at birth, because these hormones do cross the placenta and stimulate the uterine lining, which sheds when the hormones are withdrawn. Usually happens from 2nd to 10th day of life, may last 3 to 4 days. It is usually coming in as a blood-tinged pink vaginal discharge. So no treatment required. Risk factors are the low birth weight, post-term babies, also seen with preeclampsia in mothers. But we have to remember, if the bleeding is excessive and is lasting longer than 3 to 4 days, if it is in the form of pure blood coming out, it is better to evaluate these babies rather than labeling them as neonatal menstruation. Preterm ovarian hyperstimulation syndrome, or the POHS, is another thing that is a relatively rare self-limiting condition in these premature girls, usually at less than 30 weeks of gestation. There is edema of the genitalia, clitoromegaly, and in them you may find FSH, LH, and estradiol that are raised. We have to remember that FSH, LH, and estradiol would be raised in the mini puberty of the neonates, but these are preterm babies. And in addition, we find ovarian cyst. Again, this is a situation which does not need any treatment. The reason is the immature hypothalamic pituitary gonadal axis. And once the placental steroids are lost, the feedback mechanism is not well established. That's why we see this. So no treatment needed. Neonatal breast enlargement is one of the issues that we also see, happens in both sexes, so common as to be seen in about 60 to 90% of the babies, according to the literature. It may present at birth or would be seen in the first week. Cause is usually the maternal estrogen, the prolactin, and kisspeptin. Kisspeptin is usually very high in the newborns. Estrogen also causes enlargement of the lactotropic cells in the pituitary, as a result of which prolactin secretion suppresses the dopamine. A common phenomena which happens in all the cultures is handling of these breast tissue by the masseurs of the family or the professionals. They call it the so-called witch's milk. And they say that it needs to be expressed out to prevent any complication. This is not true. We have to avoid that because that would further increase the prolactin levels. We also need to remember that severe congenital hypothyroidism can cause galactorrhea due to the raised prolactin levels, and that may continue up to the 6th postnatal month. So that is also fairly common. Okay, so these were some of the situations that we discussed in an overview. The major question that I pointed out earlier is to differentiate between the treat now or watch and repeat conditions. If we think about it, the treat now includes neonatal thyrotoxicosis, the pressor-resistant hypotension, or the transient adrenal insufficiency of prematurity, the symptomatic hypocalcemia, and of course, the significant hyperkalemia, hyponatremia, which may be causing ECG changes. These are the situations where you need to treat. Watch and repeat calls is for mild raise of the TSH value, a low T4 of prematurity in acute illness, and mild or asymptomatic borderline calcium abnormalities. So the way to go is to prioritize physiology and the clinical status. The trends would guide the decisions. Unit cutoffs are very important, and a consistent follow-up should be the rule. Just wanted to ask if we have time. I have a few clinical scenarios, if it is possible to discuss. Otherwise, I'm done with my talk. So let me know if we can proceed. Right. So, okay. So I'll finish with that. Thank you. So these are my references, and thank you very much.
Thank you, Dr. Khadija.